component of services in which you're working with families in that evaluation phase, is really those first 30 days that set the foundation for a positive treatment process and a positive collaboration with caregivers and youth. The first webinar we had last week really focused on that initial part of really thinking through engagement and providing psychoeducation and beginning the collaborative process around treatment planning and goal setting. Today's webinar is going to focus on really kind of thinking through what that discharge planning or discharge criteria will be as part of the treatment plan, and thinking through in terms of tracking progress and outcomes and some specific things that, some specific strategies and resources you can utilize to help support you to stay on track. So my name is Lydia Franco. I'm a social worker and part of the CTAC resource team, and have had long-time experience working with kids and families both in direct and indirect services. With me today, I have Geraldine Burton, longtime family partner, an advocate across New York State and elsewhere, actually, and nationally. And we're very excited to have her be here today, as she was here last time as well. Yvette Kelly, who is also part of our CTAC resource team, a licensed mental health counselor, and has been working for a long time in a variety of different sectors of the children's system, most recently as a clinical director. Jason Jones, also a social worker and part of the CTAC resource team, and has worked with kids, families, and also across the spectrum. So we're very excited to have this wonderful team with different perspectives to present to you today some important things to consider around the first 30 days. Just as a reminder, everybody is currently muted. So in order to communicate with us, you'll see a chat box on the right-hand side. If you don't see that chat box, there's an icon at the top on the right-hand side that you can click, and you'll see it pop up in your panel. Make sure that when you submit a comment or a question to us, and feel free to go ahead and do that throughout the webinar, that you'll click from the drop-down Send to All Panelists and hit Send. That way that we as a panelist can see your comments, your questions, and your responses. There will also be times periodically that we may ask you a question, and we would love to hear from everybody to really get a variety of different perspectives. If there's a question that comes in, we'll try to answer it as we see it, or we may just hold it for the end in the last few minutes that we have for a Q&A session. So briefly to go through the agenda, I think what we'll do, in case there's some new folks that didn't attend the first webinar, do a brief overview of why the first 30 days are important. What's the goal? What do we want to happen at the end of the first 30 days? And what are some key components that we started talking about last time? And then we're really going to spend the majority of the time thinking about discharge planning, overcoming any challenges to discharge planning, looking at some tools and resources, also thinking through how we go about tracking progress and outcomes. And we know that with all the changes in the kids system and the move to managed care, that it's going to be extremely important for us to be able to track progress in a measurable way and to be able to provide that documentation to managed care organizations. And also, because I think it's hard to have these conversations without also thinking through what gets us off track. What is it that stops us from really hitting that goal of discharge? What is it that gets in the way of progress? So we're going to spend a little bit of time on that as well as some few minutes at the end to handle questions. So I'm going to get us started right now by passing off to Geraldine Burton, who will give a little bit of an overview from the last webinar. As a reminder, that first webinar is available on ctacny.com, our CTAC website, where you can have access to webinar recording, the slides, and also all the handouts and resources that came along with it. Today's webinar will also be posted on the website.
Okay, so again, this is a quick review. So why are the first 30 days important? Well, we know that within the first 30 days there's a high dropout rate. And when clients leave, they don't keep it to themselves. They share that information with other parents, caregivers, and most of the time when that happens, they discontinue early. They often return later with more serious difficulties because they haven't followed through. And if we aren't successful in the first 30 days, the unused and overuse of services is increased. And it's important that we do things very well in the first 30 days because of the movement in the country today is for higher accountability, demonstration of outcomes, and continuity of treatment that avoids premature dropout. It's important to establish clear and measurable discharge criteria going from clinical to subclinical. And it's important that we maintain a focus on strengths as well. Again, people, when they come in, we don't want them to stay forever, but again, it's very important that we establish things in a proper way, in a positive strength-based way within those first 30 days so we can keep them in treatment. So the goals of the first 30 days, alignment with the practitioner, clinical formulation, and caregiver's felt needs. And how do we know if this is accomplished? Well, first and foremost, there are shared goals or focus of treatment. There's an understanding of what treatment is and the role of the caregiver, the child, and the therapist in successful treatment. There is a clear agreement for the treatment plan as well. And we have to maximize the alignment process, validate and listen to the perspective of the caregiver, meeting them where they are, identify areas of common ground, and areas of disagreement, process of negotiating, explaining, and working hard to find that common goal. Sometimes that's not too easy, but again, it's something that really needs to be done, and it will definitely help you in the process moving forward and working with a parent or caregiver. So the alignment model of the first 30 days. Another name for alignment, another term for alignment is alliance, and that's very important. And as you see the lines that are pointing toward the alignment, there's the shared understanding of the treatment, clear roles in treatment. Same thing that we talked about last week. Psychoeducation is important, a collaborative treatment plan, and agreement with the child if the child is able to is older in age to be able to share that information as well. So the question is this something that you're comfortable with? Does this make sense for you and your family? Is it something that you want to do? And just remember that you, as a provider, is not driving the bus. The client, the caregiver, is driving the bus. And to be able to have this discussion, you may want to have a variety of services to offer to families. And sometimes some providers don't have that information, so it would be helpful if you would do some research and get that information as well, because there is a wealth of information that is available. As I said last week, Families Together in New York State has a list of family parent partners throughout the region that can be very helpful in this process as well. So please utilize that information as well. So the key components of the first 30 days, as we said, initial engagement, very important, clinical formulation and assessment, and collaborative treatment planning and goal setting. All of these are extremely important in the process. All right, so moving forward. So in order to make informed decisions, psychoeducation is very important. So we want to instill hope and reduce blame. And sometimes families, when they're coming in for treatment, that's all they've heard is blaming. You know, you didn't do this as a parent or caregiver. And then they have no hope whatsoever. So it's important that these things are done. Then it's important for providers to orient the caregiver to services. So families can make informed decisions, as we said, and helps with the treatment process. It helps the treatment process go smoother. Then there's information on the illness, and this is very important as well because it helps to calm the fears. When you don't know what it is that's going on with your child, there is a huge fear there. So at least if you have a name to put to what's going on, it can be very, very helpful. Then there's information on treatment options. Again, this goes back so that the parent caregiver can make an informed decision. And we know that there are various treatment options that are available. And we also have to remember there's not one size fits all when it comes to treatment. You have to meet the parent and the child where they are, and based upon the information that's shared, that's how you make those decisions. So overcoming provider and client barriers to do this, you have to be able to do this consistently. And this should be an ongoing process throughout the treatment, not just a one-time thing. Okay, so now I'm going to turn this over to Yvette.
Thank you, Jerry.
You're welcome.
And so I want to go back and just start with the slide that Jerry just left regarding the making informed decisions, because I just want to kind of point out how important it is for providers to do this and really do this, you know, appropriately, so that families have an understanding of, you know, what are some of the issues as you see them and how they can collaborate with you for you to, again, gain a better understanding of what's going on. So when you provide information about the services that are offered, you create an environment of choice and ultimately an environment of collaboration. If we talk about collaboration and looking, you talk about collaboration and looking at what exactly does that entail, it is really all of these elements kind of lumped into one when working with a family. So we not only gain understanding for our perspectives, but we also create an environment for the family to be understood. And I just want to comment on a chat that we got. It said, it seems there should be another step that emphasizes listening to the person's view of their illness and options before we offer any ideas that we have. And that's accurate, and this is what we're talking about in collaboration, and really listening and gaining an understanding of what's going on from the family's perspective. We should always be asking that question and including that, no matter what materials we get that says, you know, this family was referred for this particular reason. We should ask the family, do they have an understanding of why they are showing up at your agency or office today? When we talk about establishing strengths and establishing a baseline, establishing strengths does not only promote alignment with the family, but helps the family tap into internal sources of strength and fosters resilience. So that is really such an important piece in working with families, is helping them tap into their inner strengths, which sometimes they don't recognize as such. And so it really does behoove us to kind of help families look at their own internal strengths and how they can capitalize off of those. Establishing a baseline also helps with goal development and goal attainment, right? Understanding where you're starting from and understanding where you want to move to. Collaborative treatment planning, you know, when you work with families in a collaborative fashion, you will have a mutual understanding of what's important to the family and how you can work together to help them acquire the necessary knowledge and skills to improve their situation. So again, meeting with the family, talking with the family, getting their perspective, agreeing to the terms of treatment. What treatment are you going to use? What's the duration? And then at the end of the day, what will it look like when, for the family and for you as the provider to know when treatment should end? So that really should be done in the beginning. We're talking about joint selection of discharge criteria. A good assessment helps to create the discharge criteria, right? So you have to start with, you know, again, looking really good assessment, all right? Understanding the issues from the family's perspective, understanding, you know, what the family wants to work on. Discharge planning begins at admission, and it's a crucial step that should not be skipped. It is intrinsically linked with goal setting. All right, so when you're meeting with the family, and they come to you with a problem or an issue, and you're getting their perspective and understanding that, you want to know where is it that they want to end up? What is it that they want to get from your service? It should be clearly stated in the plan and shared with the individual and family. This is not anything that should be held in secret, and the family should be informed of this day one. It's not something that 4 months down the road they're just getting an understanding of what are some of the things that need to be seen in order for discharge to happen. And I think that's very important because there are, just in my own experiences and working in clinics, sometimes families come to the conclusion that services should end you know, prior to what, you know, the therapist or clinician thinks. And sometimes it's often a shock when a family thinks that they've met all of their goals, but yet, you know, at a service provider meeting, the therapist is saying that they're close to meeting or they haven't met them. So having a shared understanding with the family and checking in with the family to make sure that you guys remain on the same page is going to be so essential. So you want to ask the individual, the family, what would need to change so that they could manage on their own and not be in need of mental health treatment? So what would that look like? How would things be different for you if our work has made a difference? What do you hope that we are able to accomplish together? Right? All good questions that you should be asking and talking with the family about. We're talking about your treatment and the impact that you're expecting your treatment to have. It always comes down to a kind of a key question that you need to ask yourself around as it relates to discharge planning. Right? How do you bring a person from clinical to subclinical? What are some of those behavioral indicators that you're going to be looking for to let you know that you're on the right track? And at the end of the treatment session, are there, you know, what are the functional deficits that you are working to remediate, and have you remediated them? All those should be triggers into your understanding about where the family is in treatment and how much more work needs to be done with the family.
And so if I can jump in for a second, I think sometimes, especially I know myself in working with families, sometimes we got stuck with this because it wasn't clear as to what was the discharge criteria or what was the goal. And also that sometimes there was this expectation that everything would be perfect, that there wouldn't be any symptoms, or that there would no longer be any crises or issues that come up. And what would end up happening sometimes, and I think I've also seen this in working with other programs as well, is that you end up having people stay on. And then you end up, they don't come unless there's a crisis. And then what you have is like a caseload of a number of people that are just showing up when they need something, but they don't really need the ongoing service. And I think the key message here is not that everything is going to be perfect, not that there aren't going to be any issues, but the discharge criteria should really take into account that move from clinical to subclinical. And as Yvette had mentioned, Yvette and I had spent some time talking about this too, is are there any functional deficits left? And if there aren't any, then it's time to close, right? And it's time to support them in moving on, or maybe a step down of service or some sort. But I thought that those are really key, helpful questions that you had brought that I think is really helpful for all of us to take into account, and also for the families to know that that's what you're working towards.
Yes. And I think families say this in many different ways, and one of the ways, and this is really how it kind of came to my radar and my oversight of the clinic, is that, you know, after looking through some data, I realized I was trying to mitigate a no-show rate, and realized that after about 4 to 6 months of treatment for families who attended consistently, they dropped off. They started no-showing, and so it was the data was so overwhelming that really kind of said to me, that family was telling me that they were done, or they were telling the therapist that they were done, that they got to where they needed to get to. And it was such a marked kind of drop-off. And in our clinic, we had the habit of sometimes keeping clients, participants longer than they needed to, and they were telling us that, and they were telling us that in the data. And so I think that's very important. When we talk about discharge planning, we're talking about planning that is clear, that is collaborative, again, working with the family, getting their understanding of where it is that they want to be, what goals they want to work on, how committed they want to be, and align with families. If we do that in a again, using all of those elements from the collaboration wheel, we may prevent some of this. Therapist reluctance to end treatment, even if the participant indicates that they're ready, right, either through meeting goals or verbally that they've come to the end of their road for the moment. That sometimes families are reluctant to end or have become dependent on services, and I know that there are a number of families who've been in treatment for years and years, and the thought of not coming to treatment on some schedule, or not having a provider to reach out to, is actually pretty scary for them. And so how do you work with that family to empower them, right, to connect them to other natural resources that will help help them continue their work out in the community, but without necessarily the high-end level of service that you provide. And how do you convey that to the family? Because I think sometimes what happens is that families, they get so reluctant, and in our kind of technical language, you may say that, they're sabotaging their discharge. But if you find that that's happening, you really need to have a conversation with the family and come up with a plan that's agreeable, but also relates to them that you have faith that they can go out in the community and practice the skills that they have. But you also want to let them know that should a new issue present itself, should a new concern come that they can't, deal with, that they can always come back to you. And so you want to make sure that you convey that to them. And sometimes that's what it takes to get them out the door. And then the lack of focus of treatment, especially with complex cases. Sometimes cases come to us, they have multiple issues, or they have the crisis of the day, and so we don't spend our time necessarily working on the treatment plan, but we're managing the crises. And so, again, as we move through this presentation, you'll see some strategies for addressing some of those issues.
And so you may have a question, it's like, why are we talking about discharge planning now? This is supposed to be about the first 30 days, and I think the clear message here is that we have to start planning for discharge from day one. The discussion of what it is that we're working towards really should occur in those first 30 days as you're developing the treatment plan, and it is part of the treatment plan. But what we want to highlight is the importance of having that conversation. So not only so that it's clear as to what the family is working towards, what you as a provider are working towards, but also that it helps you to stay on track with services, and you're less likely to veer off if all of this is communicated in the beginning to set that foundation.
So let's talk about how do we track progress. I think, first and foremost, we have to utilize standardized assessments of families and reassess as needed, okay? So knowing that things are very dynamic, and, we need to always be consistently reassessing as we see the individual progress through their treatment. We need to be able to create behavioral indicators with families. Again, so when you're asking that question is, what are some of the things that you need to be successful? What is that going to look like? You got to be able to track and monitor that to determine if you're on the right path or if there's a modification needed. You need to get consistent and regular feedback. Ask your families, is it working? Is there something that you think might work better? You have to really solicit that feedback from them in order to understand whether or not the path that you're continuing on is the right path to be on. There are a lot of helpful resources that we include in here. We have a treatment planner worksheet that kind of outlines exactly what are some of those things that you're working on, what are some of those behavioral indicators, and how are you going to monitor and track that. We have a session planner worksheet that helps you plan your session. We should not be kind of flying by the seat of our pants every time the client comes in. We don't have, their goals that we're going to address for that day, or we don't have a plan in place. We really should be putting a lot of kind of prep work into meeting with our families. And again, we have to use some kind of tracking system. You won't be able to know, again, if you're on the right track if you're actually not tracking the data. So that's going to be very important.
So we're going to go into each one briefly. So I'm not going to spend a lot of time on standardized measures. I think everybody kind of knows what these are. There's a helpful resource here. I know here as part of CTEC, we hope to develop some additional helpful resources for you in tracking outcomes in the next few months. But what I wanted to highlight here is that when we're talking about kid services, when we're talking about working with families, I think all too often, and I know this was the case for myself, is that we're not also assessing the family functioning or the family context. That oftentimes when we're talking about measures or communicating with families and assessing them, that it oftentimes really more focuses on the symptomatology, it focuses on the sort of that presenting problem, And we spend a little bit of time talking about the family. Maybe we do a genogram, maybe we ask about other things that are going on in the family. But an actual family functioning assessment, I don't think is done very often. And there are a couple tools. So here there's one that's the family assessment device. And again, these slides will be on our website for you. And I believe that one, it may be copyrighted, but you get to kind of see an example of it. And it's long, but you can kind of break it up by subscales and use a general subscale. But there are other ones out there as well. To really kind of tap into how well is the family doing as a whole. We know that kids really aren't independent of their families, especially younger children, and that having the family really a part of that process from day one will help you have a clearer picture and will help you to collaborate and partner with the family more easily. Also understanding what those contextual structures may be may help you to understand sort of what some of the complexity may be in some of the cases earlier on, as opposed to waiting when something comes up and it hits you further once you're much further in treatment. The main message, I think, with scales, whether this one or other kind of behavioral measures, is not to overwhelm them with scales, but to judiciously choose which ones are needed. And I would argue that you definitely should have a family assessment of some sort. In there are brief ones, and then really kind of thinking through what other ones are necessary, whether a comprehensive one that touches on different symptoms or just picking and choosing which one to use at which time. We did want to really highlight, though, that not everything needs to be measured in by using a standardized scale. Obviously, those scales are very important and very helpful, but that there are also other ways of thinking through and maybe an idiographic or behavioral indicator of some sort that the family decides is oftentimes just as helpful, just as long as it's tracked. So when a family comes in, so we at the end of the last webinar, we did a brief role play with Yvette and Jerry, kind of thinking through some challenges that a parent is having with their child is acting out at school, distracted, they're getting a lot of calls from school. So kind of thinking through what would be a good, indicator, what would be a good indicator for that parent. So maybe it's less outbursts, maybe it's something else, like less communication from the school. It could be lots of different things. But it doesn't have to be these very long and involved measures. If a child is cutting, maybe it's just how many times have you cut. So they're really kind of simplifying. But the key here with these is that the client chooses or the caregiver chooses what it is that's tracked. And if you can identify, they can choose that, then it's also highlighting what their felt need is in this process. And then you're more likely to kind of engage them in that process and in the tracking if they're able to attend to what they feel is the felt need at that time. So identify concerns specific to the parent, identify concerns specific to the child, identify concerns specific to other settings, so school, home, community, other programs. Create something that's simple, attainable, and easily tracked. Consider whether a simple worksheet may be helpful, and collaboratively discuss the progress using the tracking system with both the caregiver and the client periodically. And this is one example of, this is not a standardized scale, but this is one example of maybe kind of thinking through, if a child is experiencing a lot of worries or anxiety and helping them track on a daily basis. Again, it could be a simple count. How many times did I get calls from school? It could be how many times was there an incident of cutting? It could be how many tantrums there were. But really something that's simple and easy for everyone to track, but that they choose that indicator, something that they are interested in reducing and focused on.
Thank you, Lydia. So the next slide is really talking about family feedback and how critical it is and how important it is for us as providers to incorporate feedback into every session and create this culture. Create the culture of asking the participant, the family, the individual, how do you think the session went? Are there things that you think we could have done better? You always want to summarize the session again and ask for how they think it went. And you have to be, as a provider, you have to be open to feedback, and not just for the sake of being open to feedback, but also adjusting your methods if you get feedback that says a particular intervention was not helpful or a particular style was not helpful. You need to be able to talk with the family about that. And this is one of the things that I often joke when I was a supervisor, is that we want so much, we want to offer so much feedback to families, but yet sometimes we're resistant in accepting it. And so we have to really create that culture. And we want to let our families know that we want them to be honest with us about how the session went, because it's going to be helpful for us as providers to work with other families. So I just didn't want to underscore how important that is.
So I'm just going to bring up one tool that could be helpful. There's also a resource at the bottom. There's a model out there called feedback-informed treatment. They have a couple different measures that help to collect feedback within the session. And we have one version that we utilize here with our adult engagement project that we thought would be helpful to offer to you as well, is a session feedback form. So again, at the end, it's something brief. And if you're working with kids, it could just be like a face. I'm thinking like a pain scale, so like a happy face and an unhappy face and where they are in terms of how they feel about the session. With a caregiver, it could be something more involved. Or it could just be a quick, you know, can you tell me how do you think it went today at the end of every session, and it doesn't have to be very involved or long, so it can really become integrated into the process of the services that you provide.
All right, so these are some summary slides on assessment and how important it is to continuously assess and reassess. Know that evaluation is a continual activity, and it's not an event that marks the start and end of an episode of care, so you're always doing it. The work of supporting an individual and family towards recovery and wellness involves this process of assessment and reassessment and aligning and realigning. Continual review is needed to ensure that you understand the unique needs of the individual or the family. And the task is to review and evaluate the progress toward achieving the goals that you guys have set forth collaboratively. That's the ultimate task. Assessment and reassessment should occur at several key points in the overall service delivery process. And again, the information is gathered to help you evaluate the trip, so whether you're on the right road, to monitor your progress, and to direct any mid-course corrections or even detours to the points of interest. This helps ensure that the plan is dynamic, so it's growing or changing as the individual is and relative to their needs. It's current, it's relevant, and contains up-to-date reflections of what the individuals and families' challenges and needs are. And here's the key point, that they actually utilize it. You know, it's actually utilize the treatment that you're working with a family, that they're actually utilizing that as a way to help mitigate some of their issues. And so you always want to be assessing that with families. A true commitment to recovery means fostering independence of the individual and family and not fostering dependence on service delivery systems and professionals. And I think that's so important. Oftentimes we see families who maybe and think that they could not live productive lives without the help of long-term services from a variety of delivery systems. But if they have that ability, we really should be fostering that and encouraging them and empowering them to be able to do that. We have an obligation as providers to repeatedly reevaluate the individuals and the family's readiness to discontinue services, either entirely or their ability to transition to a lower level of care. I think it's important to know that sometimes individuals who are leaving our higher level of care do not necessarily need ongoing professional services, but they can preserve their gains and make continued progress with a mix of community, family, and peer-based support. And I think that's so important. You know, it's on us to really kind of try to find some natural resources and supports for our families.
And what I want to highlight, though, is that, so again, we're also talking about, you know, after treatment, but that the idea is these supports can also be implemented early on. So we have, as Jerry had mentioned earlier, there's a number of family support programs across the state. In New York City, there's family resource centers. You really can begin to connect families early on and build that support network and not really wait till, you know, you think that they're ready to go, but help support them throughout the process. And really just highlighting the importance of thinking through this process. So we've kind of taken you from those first 30 days and thinking through about what's going to happen after discharge. But the idea is, and our recommendation really is to think through that process in the beginning and plan out what do you think the treatment process is going to look like. That had mentioned earlier using some tools that we have, and we've utilized these tools from some of our other initiative, so it may look familiar to some of you, but I wanted to highlight it here. So for example, this is a sort of a collaborative treatment planner decision-making guide. It's really a scratch pad for planning which elements will be best to use during what phase of treatment. And so, for example, in the beginning when you're doing the treatment planning process and the goal setting process, you may decide to use some type of standardized curriculum, so an evidence-based practice that has a manual, and you really actually know and you can show the family what that whole treatment process is going to look like from beginning to end because you have something in hand. However, we don't always use those curriculums, right? So, or we adapt them significantly. So what is it that we're doing? Should we also be creating a plan from beginning to end of the whole treatment process as to what are the different strategies and clinical tools that we will be utilizing? So for example, thinking through what the beginning phase of treatment is going to look like, the middle and the end phase of treatment is going to look like. So if you have a child with depression, chances are we should be utilizing some type of cognitive approach, cognitive restructuring. But as we're thinking through that process, and I'm sure many of you already do this in some way, but maybe documenting it could also help kind of track and support, and also it's something that you can show families. So it's cognitive restructuring you wouldn't do at the beginning of treatment, and you probably wouldn't wait to the end of treatment, right? Because chances are you wouldn't be able to get to the end without doing that if it's a pretty significant case of depression. But in the beginning, typically we think about providing psychoeducation and engagement and maybe doing some problem solving, doing some social skill building. There's some things that need to happen prior to doing the cognitive aspect of depression treatment. So kind of really thinking through, okay, you know, these are some things I want to work on and in the beginning, and then I think I want to move to these kinds of practices, and in the end, this is what I would like to do. And I think that helps, similar to having a curriculum in hand, that also helps for the family to understand what that process is going to look like if you don't have that curriculum, but also helps you to stay on track. So the key message to all this is that having clear goals, having clear ways of tracking helps you to stay on track with services and helps make it clear to the families and to the provider as to where things are headed and what's going on. What I want to highlight about this little worksheet is also that there's this other stressor section at the bottom, and oftentimes it's easy for us to get off track, usually by some type of crisis or stressor, so something that kind of can creep up and get in the way. So if it's an opportunity, and some of you already do this in treatment plans with barriers or challenges, and you also highlight strengths, but it's also critical to kind of think through what do you think are some potential challenges that are going to pop up, some crises that may pop up, and thinking through from the beginning what are some potential ways of preventing that from happening. Because the idea is if we then move away from the focus of treatment and what the goal is and focus on the crises, then we never really get to the heart of why they came, and we never see significant improvement outcomes. We just get used to putting out the fires. But if we can stay on track and on focus, ideally those fires start going away on their own because you've been able to really attend to it by looking at the bigger picture.
And I just want to say to that, Lydia, it also role models helping families kind of be proactive in trying of managing and on the back end may prevent some of those crises of the day. So it helps the family think through. You know, most of our families are thinking day to day because that's where they are, but it helps them think through what are some of their challenges. How can we kind of get ahead of some of these challenges? Or, you know, if we've already addressed or looked at that might be a challenge that comes up. When it comes up, perhaps the family's going to say, hey, you know that challenge we spoke about? Well, it's presenting itself, and how are we going to work against it? And that's really what you're hoping to do. It's a great tool to help the families kind of move from that in-the-moment thinking to future thinking.
Great. And there's another example here is also a session planner. Again, this is something to utilize at the beginning of services to kind of think through then what is each session going to look like. So again, if you have a standardized curriculum, that's probably already laid out for you. But if you don't, how do we structure the sessions, right? What is the beginning, the middle, end of each session? So treatment planner is the whole treatment process from beginning through discharge. The session planner is each individual session. And then creating an opportunity in which to ensure that at the beginning of session you're welcoming people in. The middle of the session would be the heart of that session, what the intervention strategy would be, and the end really focusing on getting that feedback, maybe using the session feedback form, maybe asking for for feedback, and also summarizing strengths. So if you can kind of lay out the session briefly with some sort of key points for the beginning, middle, and end of your session, then you're structuring a session and it prevents you from going off track. It also helps create a structure for the families and for the caregivers and for the youth. Then they know also what to expect. And when you know what to expect, the service is a little less scary. You start feeling more comfortable. You start feeling safer. And that really enhances the collaboration, that enhances the engagement, and then you're more likely to really retain families and have families that participate. So we wanted to highlight there for you. And again, you can do this any which way. This is just the one example that we have of something that you can utilize. So we wanted to move on to thinking through staying on track. I do want to offer all of you an opportunity to kind of chat in with us, sort of what are some idiographic or behavioral measures that you've been utilizing. We'd like to hear from you some feedback. What are some things that you do to help you stay on track so that you can keep staying on the focus of treatment? And if you have any specific strategies and maybe something we haven't mentioned or haven't thought about, please share that. And also, what are some other standardized scales that you utilize, too, because we can also share that with everybody. So please use that chat box and make sure to send to all panelists and give us some feedback on this process. Are you utilizing it? What are you doing for each of these components? Do you have any challenges with them? So Jason's going to talk a little bit about overcoming challenges.
So thank you, Lydia. And as previously mentioned, it's so easy to get sidetracked throughout the course of treatment, and there are often competing demands and crises that do arise, but anticipating challenges can help you stay focused on the goals of treatment. And I think the key point here is that when in doubt, really return to the first 30 days and what was discussed and agreed upon with the family. So as we mentioned, a crisis may occur every week, and if you really find yourself responding to those rather than the actual clinical focus, you're going to be putting out small fires rather than staying with the goal that the family agreed upon in the beginning. So really think about what is the scope of work that was agreed upon and how can you remain dedicated to those goals. So understanding a stalled treatment process and thinking through the decision-making process. So really start with the diagnosis. Was there a problem with it? Have you assessed the problem correctly? Maybe you don't have enough information. Maybe there was something that was missing. You have more information now. Have you assessed the strengths of the family, and how can you use that to really reformulate the diagnosis? Have you assessed and addressed the practical barriers that disrupt the treatment process? Maybe there are things that are interrupting their ability to work with you. And then consider the problem of the practitioner and caregiver and child misalignment. Perhaps have you been successful in engaging the family? Do they feel engaged, and how do you know that? Have you thought through cultural values, beliefs, and preferences that may be interfering with the process of engagement? And is there a discrepancy between the treatment plan aims and the felt need of the caregiver and the child? So maybe your idea of the goal for the family does not align with theirs. So this is just a formal way of really going through that process. So question one, have we used the right approaches and treatment interventions? So what was the original clinical focus and how was it decided upon? How was the diagnosis made and who was involved? Really try to think through that with the family and really ask for their feedback throughout the entire process. And again, review the core clinical problem that has been the focus of treatment. And continuing that, review the interventions and the approaches. So what interventions have you already tried? What interventions can you try? And for the ones that you have used, were they used correctly? So I really do want to highlight here that Lydia mentioned you could go back to the treatment planner at this step. And that's really important because once you find yourself straying away from what you did agree upon, you can go back there and really reconsider what needs to be done. And question two, have we applied the intervention skillfully? So there may be problems with dosage and duration. So were there missed appointments? That, of course, could impede progress. And maybe there was lack of homework. Perhaps the family needed something to do in between sessions that would help. Also think about the order of intervention strategies. Again, go back to the treatment planner. Perhaps there are strategies that you could be using before others. And make sure that when you're adapting an intervention, you really keep the core ingredients and the goals in mind. So variation is great, but if it deviates from the goals, then it may not be successful.
Yeah, so I think that the idea here is that there's a lot of key questions to kind of consider when you find yourself kind of stalled in treatment or that things really aren't getting better. So what are some things that occurred, especially in those first 30 days, around the diagnosis, around engagement, around the treatment plan, the actual interventions that are utilizing? Did you do too much or too little of something? Are the families really, are they not attending and that's why they're not getting a full dosage? What are the intervention strategies, and should we rethink those or do them a little bit differently? And that's why having that plan and that treatment planner is particularly helpful, because you can go back to that. And you can go back and see what is it that I did and kind of check off as you go along and kind of rethink how to move those around. And a big part of this is also getting feedback from the family.
So, and again, when measures say different things, so perhaps you're using a standardized measure as well as an idiographic measure. And if they both say the same thing, then there's alignment with the family. You have the same perception. But oftentimes there may be a misalignment, and that's when you have to revisit the measure. So make sure that the idiographic measure is measuring what the family goals are. Assess if it's measuring the right goal, or perhaps the goal needs to be changed. And if you're using a standardized measure, is it tapping into the right problem? And is the measure easily understood by the family? So really reassessing that with them is key.
Right, and I think you know, because if you're tracking regularly, if you see that the treatment is stalling or there's worsening, if the family is getting worse in participation or in their symptoms or in what's going on in the family, tracking that progress will help you to highlight at what point there was some type of a turning point, if at all, right? That making sure you have that on a regular basis, that you have that data tracking system, whether it's an Excel spreadsheet, whether it's something in your EHR, or whether you have access to some other type of system, or it could just be, you know, a paper form that the family gives you, and then you kind of sit alongside of them and continue to track that way, and later you translate it to the EHR in some way. But the idea being is that there is consistent and regular tracking, because that's going to help you figure out what isn't going well if and when you get there. And that sometimes the perspective of the family may say something different, and that'll come across in the tracking. So you may not be on the same page with them, or they may not be on the same page with you, and then using those measures will help to highlight what is it that is potentially the problem. So is it that the goals have changed and we have to rethink it? Are we not really measuring the right thing? Should we actually be measuring something else? How can we go back to that initial concept of alignment and engagement and have those conversations and get that feedback from family? So I do want to offer everybody to please submit your questions now, because we do have a couple minutes at the end that we can kind of answer some questions. Really want to focus on applying some of the concepts from today's webinar around tracking and progress. I also would love to see some feedback from all of you around what is it that you utilize, how do you track what's going on. Have you not been able to figure out a good system yet and you're still trying to figure out? Please let us know and give us that feedback. But we also want you to also submit, if you can, just one example of an idiographic measure used with families. And again, idiographic is really more of the client-led measure, or a behavioral measure of some sort that they have utilized. So could you submit an example of one? So we've said calls on the phone or the cutting incidences or things like that. So if you can, as we move forward, if you can submit some of those examples to us, that would be really wonderful. And so we also wanted to thank you. There's a few coming in sort of looking at anger, some mood issues, similar to also the anxiety ones that I had. Others are coming in that focus on outbursts. Others are focusing. The other thing is also to flip it and be more positive too. So we also have some that are coming in that are more about positive interactions with peers, for example, and then they're tracking positive interactions, because kind of really thinking through goals in a more positive and strength-based way is helpful. So thank you for all the feedback. We want to move on to a brief role play. So at the end of last webinar, we also gave a little bit of an example between Yvette and Jerry, Jerry being the parent, Yvette as the provider, and we wanted to continue that example with a little bit around tracking progress.
All right, good afternoon, Jerry. Last week when we met, we started discussing how we were going to work together to help Marcus increase his self-management skills at school and hopefully reduce some of those phone calls that you're getting. And so just wanted to know what your thoughts about that were.
You know, yes, and I was thinking about the chart idea that you mentioned, and I don't think that it's going to work. I have used charts in the past, and they don't really work for me for whatever reason.
Okay. Can you tell me a little bit about that in terms of what hasn't worked for you?
Well, my son's school had me do something. I don't remember what it was, and it was just too much for me with everything else that I had to do. And with all that I was going through, I was just frustrated with all the calls and I was getting from the school. So to be honest, I really didn't take the time to really do it.
Okay. Yeah, I know sometimes tracking can be pretty time-consuming for families, but you know, what I'm hoping we can do is really maybe try again, because it seems like perhaps it was just that timing that was not helpful. And so maybe what we can do you think if we were able to, say, just track behavior progress, say, in the morning, instead of tracking all day, maybe we could just do one time per day. Do you think that would be doable for you?
That sounds very good. I think I can do that, and I really appreciate how supportive you've been in the process thus far, and how, you know, you heard what I had to say and really partnered with us. So I really, really appreciate that. Thank you.
Oh, I appreciate that. And I think what I also might do, just to kind of help us out, is maybe if we contacted the school and perhaps had them track a portion of the day, so that way you're tracking in the morning, they'd be tracking in the afternoon, and we could come away with some data in terms of, you know, how is he doing in school, because that really is where the concern is.
Right.
So maybe we can elicit the school to help us out in that sense.
I think that will work. And are you going to contact the school, or do you want me to do it? How is that going to work?
Yeah, I will contact the school. I'll contact the teacher and talk with them. But I also think it's important that once you know, this plan, that we kind of look at this every time you come into session, so we could kind of figure out, you know, whether what we're doing at home is working and whether that's translating to school and vice versa. So it's going to be important for us to be able to review this every week. And then if things aren't working, if you find, like, you know, the plan is not working, just bring that back here and let us know, and then we can work together to kind of figure out a different plan. And then we'll try that out, and we'll see how that works.
That sounds really, really great. And, again, it's very much appreciated. This is not the experience I had at the school. So thank you very much.
Good. You know, Jerry, you know, I just want to wrap up our session, but I also want to give you the opportunity to provide me some feedback. I know you did, and I appreciate it, but to provide me some feedback through a resurvey, just in reference to kind of your experience. I do use that information to really help me work with other families, and so I'm hoping you feel comfortable in giving me some honest feedback.
Oh, okay, absolutely, sure.
Thank you.
You're welcome.
Great, thank you, everybody, and thank you for that lovely role play. So an example really of like how to kind of identify something to track, how to have a little bit of a discussion around some challenges in tracking, and also being able to wrap up that session to get some feedback. There's a variety of different ways to do that. This is one example, and you can also even spend some more time. We were doing a quick role play, kind of really puzzling through what are some challenges that could get in the way of tracking, or what has gotten in the way in the past for Jerry, since she mentioned she's done something similar before and can spend a little bit more time and get a little bit more concrete. So that's also possible. So I'm going to go ahead, and as we're waiting to see if there's any additional questions or comments from folks, please submit those in the chat box now. I'm going to go ahead and kind of just give you a brief overview of what's coming up next. So as we mentioned, we're really kind of focusing on the alignment with families, understanding of treatment, clear roles, psychoeducation, collaborative treatment planning, the agreement with the child, really focusing on strengths and the importance of that for both the caregiver and the child. That collaboration is an important aspect both within the first 30 days and throughout treatment. But what I wanted to spend a minute really talking to you about is our consultation webinar. So the way we've set up this series is that it's running from now through June, actually, and there's going to be a number of different webinars. So this first set on the first 30 days really focus on the engagement and goal setting and treatment planning aspect of it, as well as tracking progress. And we wanted to offer you an opportunity for next Wednesday, February 18th from 12 to 1 to have a consultation webinar. So you'll sign up and participate similar to today, but that we ask you to bring in some examples, some questions that you may have about applying or utilizing the concepts. We want you to, if at all possible, really use the first 30 days checklist. We spent some time in the last webinar going through this. This is available on the ctacny.com website. And this is something that you as a provider can utilize with your own families to kind of assess how well you're applying some of these concepts that we've mentioned in these first two webinars. If you're a supervisor or a director, you can also utilize the same assessment with your staff. Maybe attend a staff meeting, really kind of sit around with everybody and talk through, are people utilizing this on a regular basis, or even maybe observe some meetings. Because a big part of it is as we kind of move forward and we focus on applying some of these concepts, but also having the demands of paperwork, it becomes a bit of a challenge to just ensure that we're consistent in applying all of these concepts. So I just wanted to highlight to use the first 30 days checklist, attend our webinar, and get some feedback, some problem solving, some suggestions on how to apply these concepts. We have one question that maybe I'll pose to Yvette and Jerry. What happens when you ask questions and the person agrees but either does not return for the next session or comes in and says they forgot to do the homework? It seems you could potentially spend a great deal of time working through those roadblocks.
Yes, that's a great question. I think sometimes we have to understand that families are telling us things through their actions, and so I always go back, because sometimes families are not necessarily upfront with, you know, that plan really doesn't work for me, or, you know, it really doesn't seem doable, and so you really have to spend some time teasing that out. So if that happens and the family agreed and you let the family walk out and then they never arrived, you want to do some outreach. You want to go back there. You want to kind of see, is it that something came up that they completely were not expecting, and that really derailed them. And homework is kind of that iffy issue. Sometimes our families will not do homework. I traditionally have not had great success in having families do complicated homework. They could do very simple homework. If I ask, for them to go home and just track by using a chart, track by yes or no, they'll be able to do that. But when it becomes more daunting than that, I find that that getting it back is really challenging. So you might want to find a different strategy. Maybe if you ask them to do the homework, maybe you actually call them to check in to see if they actually did it instead of having them bring it back. Yeah. So I want you to try a particular skill on this day. Let me know how it works. You might call them the following day and say, did you try the skill? Can you tell me how it works? Instead of them bringing back like a piece of paper.
And you can also maybe even role play it a bit, right? Or rehearse it in the session. Sometimes it's more about the application and not so much that they disagree with it, but they don't know how to really do it, or they didn't do it well and they don't feel like they can say that.
Or time.
There's a number of different issues, but I think the key message there is to kind of tease that out a little bit more and continue to kind of work with families in that collaborative fashion, and it'll usually come to light.
Or maybe, instead of using the word homework, because homework sometimes has a negative connotation, parents would say, I'm not in school anymore, I don't want to do homework. So using another word, I know when we do one of our curriculums, the 4Rs and 2Ss, we use the word road work, but that's here in New York City. But then it could apply to upstate as well. Again, meeting the family where they are, asking them what got in the way, what can we do to make sure that, this is done. The other thing is, since mostly everybody has phones, maybe suggest that they set up something on their phone to remind them to do it before.
An alert,
Right, an alert before they get to the next session.
Yeah, and just one last comment. I found that homework works best for the participants that I have a really good relationship with. So I think, as you work with them longer and you begin to develop that rapport, that the ability for them to do homework is going to become more and more, you know, there will be more and more willing and able to do it. I think, so sometimes, you know, starting out, you know, first few sessions with giving homework is probably not the best strategy.
Right. Yeah.
You know, but once you build a rapport with the individual, you might find that they you know, getting the homework back, you might be a lot more successful.
Great. Thank you so much, Yvette and Jerry and Jason, for participating in today's webinar. I just want to wrap us up a little bit. So make sure to check the ctacny.com website for the webinar recordings, the slides, and all the different handouts. You'll find the first 30 days checklist there, so we highly recommend looking at that checklist or utilizing it before coming to our consultation webinar. Again, it's an open optional consultation webinar to talk about applying these concepts next Wednesday, the 18th, from 12 to 1. And then the next core area after that consultation webinar is going to go a little bit more in-depth into caregiver engagement strategies. And that first webinar is March 4th from 12 to 1. So please make sure to sign up and check your email for announcements. This is our contact information. Feel free to reach us or go to our ctacny.com website. And again, the recording, the slides, everything will be posted on the website. Thank you so much for participating in today's webinar, for providing your comments and your feedback, and we hope to see you next week in our consultation webinar. Thank you.